30 minutes. Je vous donne la parole et vous êtes face à face avec nos collègues ORL de Suisse.
Parfait. Can I start?
Oui.
Okay.
La parole est à vous.
Okay. Okay, great. So first of all, I need to share my screen. So I will go like this, and then we can start with the first slide. Let me see. That's it. So first of all, it's a tremendous pleasure. I must tell you that it's a real tremendous pleasure to be with you. Unfortunately, my Arabic language is not that good, so I have to give this presentation in English. So hope you forgive me. So again, real pleasure to be there. You know, I need to tell you that I was invited to come to Syria. That was something like around 12 years ago.
Doctor,
I was invited by the Syrian ENT Society to give some talks and also to operate. And it was great. I went to Damascus, and then I moved from Damascus to Aleppo. And I remember the great time I had with lots of really good friends that I met and I already seen before. You know that many surgeons are coming to the Cost Clinic, and I have many friends in Syria. And of course, we all know the difficult time you passed through. And again, we were all thinking about you, all of you. And I'm really close to all my friends. I've been traveling a lot to all Middle East countries, and I know that also I have my Egyptian friends who are part of this Congress. So, I mean, it's a real pleasure, and I really hope that I will be able to come back again to your country, which, as you know, of course you know, is the birth of our civilization. So let's talk about stapes now. So what I will plan to do, I have two talks. My first talk will be related to stapes surgery, mainly, of course, talking about otosclerosis. And then I will talk about ossiculoplasty. So in my talk on stapes surgery, the subtitle, as you can see, is called Basics to Complications, which means I'm going to give you, to present the technique I'm using for the primary surgery for otosclerosis when we are encountering basic situations, but I will also talk about a complication in which we need to know how to deal with this. And of course, the plan will be to give you my advices, to show you how I do it, and of course there is no doubt that I don't want to tell you that my technique is the best one. All of us, we all have different techniques, and whatever we do, if we are happy with the technique we use, I think it works fine and there's no way to change. But I'm here to give you my tips that may help you, I guess, if you encounter a difficult case. So if we go now to the next slide, I try to change my slide. Now here is the next slide. So I will show you the global technique, and then I will go back to a step-by-step technique. This is a transcanal approach right here. I'm going to perform the incision using a speculum holder, as you can see, and a round knife like this, which is making a skin incision. As you know, this is typically transcanal, purely transcanal. So I'm now elevating the tympanomeatal flap using a sucker on my left hand and the elevator, a smooth elevator on my right hand. So I'm following horizontal line like this, as you can see, until I reach the annulus, and then I can open the mucosa of the middle ear with a needle like this, and then I will elevate the flap. So we just need to elevate the posterior part of the flap. The next step will be to get a good exposure, so I need to do a bony rim resection using a curette. We know that what we want to see when we perform transcanal approach are the two landmarks, which are the facial nerve, which is the main one, of course, but also I like to expose the pyramidal process of the stapes tendon. And I would advise that we don't do anything around the stapes until we have that kind of exposure with the two landmarks, the facial nerve right here, of course, and the pyramidal process. Then the next step will be to do the ankle-induced tapete joint separation. And the tip I give you is, you can see I'm using a sucker will hold the incus when I'm doing this, and I can check the ossicular chain mobility separately, Malice incus from stapes, from the top of the head of a stapes, but we'll come back to this in more details. Then, of course, this will be followed by cutting the stapes tendon, and then we can use micro drill. I know it's not always possible to use a drill. If you don't have the drill, then you can try to break the superstructure, but of course, if you have a drill, it's always better, because you can do it very precisely, progressively, without any pressure, cutting the posterior crus, and then the anterior crus of the stapes. The point is then to remove the stapes superstructure in order to expose completely the overwhelming underfoot plate. Now we have a better view, and we can measure now the distance. I always do that using a stapes measuring rod from the mid surface of the incus to the foot plate. And then this is followed by the stapedotomy itself. You know that I'm using a stapedotomy technique with band graft, so I'm performing now a drilling out procedure of the fenestra of the labyrinth. And again, as you can see, I'm just leaving the diamond dust doing the job by itself without any pressure. You just leave the diamond dust doing the job. And of course, this is just showing this because I'm using the diamond dust, but I understand that this is not possible everywhere, but I'm here to give you the tricks that I'm using. I'm using on my left hand a 0.7 millimeter sucker to control the fluid leakage, and you can see that the sucker is placed very close to the stapedotomy, but not at exactly at the level, because the risk would be to create a dry labyrinth. Dry labyrinth is really bad. So this is now the fenestra, so I'm happy with this, and now I will cover it with the vein graft, because of course, as you know, I'm using the COS technique, which is the vein graft interposition prior introducing the prosthesis itself. So this is the vein graft, which has been prepared at the beginning of the surgery. I will come back to this later. The vein graft is introduced with the sucker in my left hand, and with the right hand I'm stretching the vein in order to cover completely and seal the labyrinth. That is the main point of this technique, the vein graft, just sealing the labyrinth. This is the COS Teflon piston, the basic one, the cheapest one I would say, that you can cut and you can accommodate to any situation. So this is a 0.4 millimeter diameter Teflon shaft. You notice that I cut the shaft and then open up the loop to break the memory of the loop of the piston, because Teflon has a memory and we need to break it. Then the last step would be to close the loop around the incus. You can use a curve forceps, but I like to use this trick of the two hooks, and then looking for the bending side. The piston should bend, but not move, which is a good sign to determine exactly, to be sure that the shaft is in good condition. Then, of course, this is followed by the introduction of a Morocell, which will move on. This will be removed on the 5th day, and then I will do a hearing test at day 6 just to check the short-term follow-up. Now, let's go for some tricks. The position you can see, I'm facing the nurse, and I'm using a speculum holder, which allows me to have both hands free. And I really strongly believe in the fact that you need to have both hands free to do this type of surgery, specifically for transcanal approach, which is a minimally invasive surgery, of course. And you can see I'm using this speculum here, which gives me a kind of a platform, which gives me a very strong stability for my hands. Now, let's go back to the step-by-step. The first step after having this type of exposure would be to do a joint separation. So the point is to gently separate the incus from the stapes prior determining and checking ossicular chain mobility. So I'm looking for using a joint knife like this. And you see again, I'm using always my left hand also to stabilize the incus while I'm doing this. Now I can check the ossicular chain mobility, checking malleus incus first with the needle like this, and then checking stapes mobility using a needle again. And I like to test it from the top of the head. That's important to do it like this. So you can see that now we can be sure that Malice lincus are mobile and only the staples is fixed. And I insist on that point because if you have a strong Malice repeating panic fixation, which sometimes could do exactly the same preoperatively as in terms of their bone gap, you cannot make clearly the difference between Malice ankylosis and stapes ankylosis, because Malice ankylosis is having sometimes a lever effect pushing the stapes down, creating a false impression of stapes fixation. So it's better to separate the joint first prior making the checking the mobility. Now, of course, I'm going to cut the tendon using microcissor basically, and this will be followed by using the laser. I use the laser, of course, in France, we have the chance at the Cosmic Clinic to have this laser, which is a CO2 laser, always with a handed probe, which allows me to be very gentle. So I vaporize the superstructure first, and then this is followed by the macrodrill. And I understand that I'm presenting a technique which is, I would say, only used by rich areas. I'm sorry for that, but I think it's just to give you the impression that what the technique we are using, but it's not mandatory to use a laser, of course. You can directly drill out the superstructure like this, but the fact that we have the laser will help to decrease the resistance of the superstructure when you vaporize the superstructure, and this will help for the drilling out procedure. What I mean is that when we want to cut the superstructure, we always want to make it very gentle. So if you don't have the laser or microdrill, it's clear that, of course, you can break the superstructure, which is more risky, of course. In that case, I don't do it myself, but I would advise that, again, you use two hands. One side, you put a needle or a circle, as the superstructure, and then with the right, you can break the posterior crus and break the anterior crus, which is more easy, as you know. Now, the next step will be to measure. Many surgeons sometimes, even in our country, do not measure. They just cut the procedure at 4.5 all the time. But it's not completely true. I have a database in which I put every patient, and I include everything, every details, every items, including the measure that I determine preoperatively, the distance between the incus and the stapes foot plate. It's clear that I have more than 6,000 primary cases now in this database. And it's true that in 75, I would say 80% of cases, it's 4.5, but we still have 25% of cases in which we find more than 4.5 or much less than 4.5. Some of them are 5 or are 3.25. It means that if we do not measure, then we put the procedure all the time at 4.5, and this could create some problems. So this is an important point. I think I would advise to measure all the time to determine. And again, here we use a combination of laser followed by microdrill, which means that I don't perform a laser stapedotomy. I always vaporize the full plate with a little setting, and then the job is finished using a microdrill. And again, of course, if you don't have the laser and if you have a microdrill, it's absolutely fine. And I understand also that if you don't have a microdrill, then you have to go to a pick, which I don't use because I have a chance to have a microdrill all the time. With the pick, you can do it, and you take your time. That's the point. We have plenty of time to perform stapedotomy. So do it very gently, step by step, until you can make a perforation like this. And then, of course, in the clinic, of the Cosmic Clinic, I use this vein graft. This vein is taken from the dorsal face of the hand at the beginning of the operation. We'll come back to this later. And we are facing now the intima of the vein, which has been pre-shaped. And the vein is introduced within the middle with the sucker and sticked to the full plate. You understand the point is that what I want to do with this is to be sure that I'm sealing the labyrinth. It's just a question of logic. We are creating a connection, a normal connection between the inner ear, which is full of liquid, and the middle ear, which is full of air. And I don't want to leave this connection without something to seal it. And I want to be sure that I'm making a very clear sealing. That's the reason why I'm using the vein graft. So I'm taking time to stretch the vein, using, again, both hands. And then this will be followed by the use of this prosthesis, which has, so we've measured, so I'm using a cutting block. and this stapes piston is introduced within the cutting block and then cut at the corresponding length. And then if I measure 4.5, then I will cut it at 4.5. And then I need to open up the loop, breaking the memory. So you notice that I'm holding the shaft like this while I'm opening the loop with the needle like this. And then I will introduce the prosthesis with the sucker within the middle ear. So you see I'm using a sucker to do that, and I will introduce the sucker within the middle ear, and then place the loop around the incus, and then, as you notice, I'm going to crimp the loop with the two hooks in order to be sure that I will not only believe in the memory of the piston. You need to help the memory of the technique by crimping it. It's not necessary to crimp it too much. Just a gentle crimping will be enough, because we don't need to put too much pressure around the incus. Now, you can use the curve forceps also to do this. In that case, you need to open up the curve forceps before and then crimp it around the loop of the piston like this, without any pressure, without pulling the incus, of course. And then looking for the bending sign. This is very easy. Just to be sure that you are located inside the stapedidotomy, especially if you use an interposition, you don't see clearly the location of the fenestra. So to be sure that everything is fine, the piston should bend but not move. I think I can tell you that if the piston is too short, then when you do this, the piston is moving away from the stapedidotomy clearly. Now that was the step by step, and now if you go to complications. Complications means difficult situation we may encounter while performing this type of operation. Just before going through this, I didn't speak about the vein graft. So the vein is taken from the dorsal face of the hand. We make a very small incision, which needs only one stitch to close. And then I remove the vein, and we need to pre-shape it. I mean, I need to remove the perivenous connective tissue to make the vein very thin, and then to cut it to make a very small part of the vein to stick it to the foot plate. I prefer to use vein graft rather than perichondrium or fascia, because vein is very thin, very elastic compared to other tissues, and it sticks very well to the foot plate. So complication. I will talk about the first one, which is obliterated foot plate, which is a very thick foot plate, completely obliterated by a very strong, very heavy, very thick autosclerotic focus, covering completely the upper window, like in this case. If you look to my series, that's an important number, the data. I've done now more than 6,000 cases of primary operation for autosclerosis, and I've published a first series of 3,000 in 2006 in the journal Otology and Neurology, but that's more or less the same incidence. But the most interesting thing, in my series, it's 2.5%, which is not that much, but 3% is quite interesting. But the most interesting one is this line. If you study my children's series, it goes up to 15%, which means there is a higher risk of facing obliterative autosclerosis. So what will be the technique? The technique I'm going to show you, is exactly the same, which means stapedidotomy with vein graft, but there's, in my mind, a different way to drill out the foot plate and a different way to measure. So this is the right ear, and you see the upper window is completely filled with a huge focus of autosclerosis. So, of course, the beginning is the same, so let's go further, and then I will use the laser, and I'm starting the procedure with the laser. But the laser is not that efficient in case of obliterative autosclerosis, so we need to drill out. And I mean, for obliterative, you really need a macro drill. With the pick, doing a pick with this would be very difficult. So you can see when I'm doing this, I'm just leaving the diamond dust doing the job by itself. I do not perform a straightforward stapedidotomy. I just enlarge the area of the drilling. I do this because if you do a straightforward stapedidotomy, it will take time. It will be too thick, and it will create a very deep tunnel, And then that could be a problem then to introduce the vein graft and the prosthesis. So just leave the diameters like this, enlarging the drilling out area like this. You can see that. And then I'm decreasing, in fact, what I'm doing, I'm decreasing the thickness of the entire foot plate in order to reach the blue line, which is the perilymphatic membrane, as we know. And as soon as I will have seen the blue line, it means that we are at the level of the stapedidomy, and now I can measure. This is the second point. I do not measure at the beginning because I do have to take into account the thickness of the foot plate. So if you measure only at the beginning, then you may cut the prosthesis too shortly. So just measure only at the end when you are absolutely sure that you are at the level of the stapedidomy. Sometimes you measure at the beginning 4, and after the drilling out area of the obliterated foot plate, it could lead to 4.75. So it's important to be sure that you measure at the right time. Now you see the foot plate, the stapedidomy has been performed, and this will be followed by the same technique in a second with the vein graft. So no pressure, take time. It's not a problem if we are doing this in 1 hour or 1.5 hours. We need to think about the safety procedure, and safety is related to time. So take your time to do it. It's not a problem. And then measuring again, and this will be, of course, followed by the same introduction of the vein graft and the prosthesis like this. Okay, the next one will be the problem of adjacent fascia nerve, which means the fascia nerve coming close to the superstructure. So let's go to this. This is not a very serious one. You can see the fascia nerve here on the right, quite close to the superstructure, but sometimes it can be even worse. But you see what, once you have identified a problem, like in this case, you know that the risk is on the right, so you just have to avoid having any contact with the fascia nerve, which is not true, in fact. You can couch it. It's not a problem with that. The point is that, of course, there is a very narrow gap between the fascia nerve and the promontory on the left. But once we have removed the superstructure, the gap will get better. So that's the first step. Just spend some time to be sure that we are removing the superstructure, like in this case. And then, after that, in many cases, if it's a very strong and severe dehiscence of the fascial nerve, you still have a small gap, like in this case. You see, I removed the superstructure, but it's not good enough. So don't try to do the stapedidomy right now, because that could be a risk. It's better to increase the approach by what I call the promontorial drilling out procedure, which is not a difficult one. And there's not much risk if we drill out the promontory like this, staying strictly perpendicular to the promontory with a diamond dust burr in order to not to go into the cochlea, of course. So you need to drill out perpendicular. And you can do it for about 0.4 millimeter, 0.5 millimeter. So it's fine. There's no problem with that. The point is that I want to increase the gap because I want to be sure that I will be safe to perform stapedidomy. In that case, you can see the entire drill burr cannot go into the oval window, and by doing this, I will be able to put the entire the burr very soon. So doing like this, drilling out the promontory, no pressure. The problem is sometimes by drilling out the promontory, it's going to bleed, but it's not a problem. You can have time to decrease the bleeding. So that's the point. And soon we'll have enough room to be able to perform a safe stapedidomy. It's always the same thing, just waiting to be sure that it's the safest time to do it without any risk, or decreasing as much as we can the risk of having a trauma to the foot plate or to the lumbar. So you see the bleeding, this is what I said. It's very frequent when we drill out the promontory to have this type of bleeding. And of course, our trick will be to use adrenaline and to wait a little bit, and it's not a problem. Then by going to do this soon, let me move a little bit away, and then you see I can start now the stapedidomy with the microdrill. Here is the stapedidomy, which is nearly done. It's safe because the entire burr now is going into the oval window. The stapedidomy has been done, and this will be followed by vein graft and again piston in the position. All right, the third one I choose is the simultaneous Malice ankylosis, which is epitympanic Malice ankylosis, which is a congenital malformation, never related to ligament fixation, always related to a poor epitympanic space, abnormal, short, small epitympanic space. So in that case, of course, I will talk about Malice two-stage pedotomy procedure. But just have a look about my series. Again, the incidence in my entire series was less than 1%, so it's very rare. And in my children series, it's close to 6%. So again, if you intend to do a stage pedotomy on a young child, be prepared that there is a higher risk of facing obliterative full plate and or Malice ankylosis. So just to show you the technique I'm using, first step, again, the most important thing is to be sure that we're going to measure, we're going to separate the joint first, followed by checking the ossicular chain mobility. Like in this right part of my slide, you can see we have a nice anterior focus here, and you can see a simultaneous Malice ankylosis with stapes ankylosis. I'm not talking about only single problem of Malice ankylosis, but I'm definitely talking about simultaneous Malice ankylosis and stapes ankylosis. So, of course, I'm going to talk about the Malice relocation technique. I will go in more detail with the osteoplasty, so I'm not going to go too much in detail, but the point is that I want to put the Malice back, more posterior, so then I can place at the end a torque on a nice vertical position. That's right here. I've already separated the joint, and after that, I can see that we have a very strongly fixed Malice right here. You're going to see that in a second. It's very strong, there is no movement. And there's also a fixed stapes. So definitely this is simultaneous Malice and stapes ankylosis. So the first step will be to remove the superstructure. And you see the Malice fixed, very strongly fixed. So let's go further. I will, of course, remove the stapes superstructure like this with a laser and a microdrill. But I just want to focus on the Malice relocation technique. So now, incus is still there, and I will do now the Malice relocation technique. First step is to dissect the Malice, which needs to be entirely separated from the tympanic membrane. I'm doing this because you can see there is a gap with a really anterior Malice. So if you leave the Malice like this, then, of course, you need to bend the prosthesis like this, which doesn't work very well. So I prefer to do it. The previous technique I was using, of course, was to cut the neck of the Malice like this, removing the head, and just using a moving Malice handle. But now I'm not doing this since I was introducing the Malice relocation technique, which I published already, as you know. So first step, entirely separated the Malice from the tympanic membrane. As you can see, I kept the incus in place because I want to have some resistance. This helps me to dissect the Malice. Once it has been done, then I will be able to remove the incus. But that's fine. I just want to check the tympanic membrane just to be sure that there is no tear. And then I will remove the incus. Always, this is, again, a transcanal approach. I don't change. I never go to endoral. So I can remove now the incus like this. And then is coming the time of the relocation. So at the moment, the Malice is fixed by the anterior ligament and the superior ligament. I will increase a little bit the gap, because when I will relocate the Malice, if I leave it like this, the neck of the Malice may come into contact with the bone, so it's better to increase a little bit the bone in resection. I'm cutting the tense tympanic tendon, and now I need to overstretch the anterior tympanomallear ligament with the needle, with instrument like this, which is close to the neck, and pulling the Malice backwards like this until I reach the resistance of the anterior ligament. Then I need to overstretch the ligament, and then what I want to have is the final position like this, where the Malice handle is overlying the foot plate. I use a hook like this. I'm sticking back the Malice to the tympanic membrane, and now comes the timing of the measurement to determine the distance from the relocated Malice to the foot plate. So I'm sticking back the Malice like this, and I'm going to use now an elongated stapes measuring rod in order to determine the distance. This one runs from 5 to 8 with 4 notches, And I'm using the mid surface of the Malice. Here we have the third notch, which means 5, 6, 7, 6, second notch. So I will cut the prosthesis at 6.5. I always had 0.5 because I take into account the deepness of the groove of the prosthesis there, but I'll come back to this. The next step, of course, will be to perform stapedidotomy. This is a very nice view of the foot plate, which is very strongly fixed. So I'm doing a rosette technique with the laser, and I'm going to drill out the stapedidotomy with the micro drill. And this will be, of course, followed by vein graft interposition. It is completely debatable, I understand that, to do a vein graft or any interposition for primary stapes surgery when you are using the incus, but when you're using the TORP, definitely we need to protect the inner ear against any risk of protrusion of the TORP within the labyrinth. This is why I think in case of using a TORP, Malice to stapedidotomy procedure, I think it is very important to use interposition like this. Now the vein is there, and now we're going to use this prosthesis, which I designed with Grace Medical. This is made in hydroxylapatite. I'm talking about the head with the central groove, as you can see, and we have a 0.4 millimeter diameter Teflon shaft. Hydroxylapatite is a nice biocompatible material. We don't need cartilage interposition. So now I'm going to cut the shaft at the corresponding length. If I measure 6, I will cut the prosthesis at 6.5. I add 0.5 because of the deepness of the groove of the prosthesis head, as I say. So 6.5 here. And I'm going to introduce the shaft within the stapedidotomy covered by the vein graft on one side. And on the other side, I will easily, because it has been relocated, so it's becoming easy to introduce the Malice within the groove. Otherwise, if you leave it anterior, then you really need to reach the anterior Malice, and this is becoming more difficult. And I like to have at the end a final vertical position of the TORP like this, and you see the introduction of the Malice within the groove, which works fine at the end. And we have at the end a final vertical position of the prosthesis with the round window sign here. Moving the prosthesis shows that we have a nice round window sign. There we go. I'm not going to talk about static fistula. We don't need to talk about that. I just want to go to two short slides, because time is limited, so I don't want to make it too long. Few different diagnoses of tricks and traps. One thing I'm going to show you, which is really interesting, because we can move to congenital malformation, which is not the case here. But if we look something like this, you have to understand that this is not otosclerosis, this is a congenital malformation, and there are lots of traps. I have many to show you, but in that case, just want to focus on stapes. So this is the left ear, and you see when I'm checking the stapes, there is no connection between the superstructure and the foot plate, but that's important. Just remember that point. So you can see there's no connection here. The superstructure is completely dislocated. This is not a traumatic dislocation. This has been since birth. And the foot plate is like, a very strong one. And you can see the facial nerve running along the promontory here on the left. So it's a malposition, abnormal root of the facial nerve. Every time you find something like this with a stapes superstructure, which is not connected to the foot plate, just think that it could be a wrong position of the facial nerve. But in that case, it's fine. Again, we have identified the problem here on the left. So we have enough gap here to perform stapedidotomy. So definitely we can do it. So I show you at the end the stapedidotomy, which will be followed by a vein graft and a reconstruction again with a piston. There's another case, same type of case, left here. Again, you see the facial nerve here running through the superstructure here. You can see the facial nerve right here. And the superstructure is not connected again to the foot plate. So there's a big trap here. You have to identify the problem again. But that's interesting. I just wanted to share you this because I think it's very interesting. And then again, here in that case, we have enough gap here to perform stapedidotomy, so we're going to do it. And then do a reconstruction with the same technique of piston attached to the incus. Now, very fast, very short presentation about my results, about this big series. Just to remember that the incidence of obliterative otosclerosis is much higher in case of children. I show you this. In terms of reconstruction, In most of the cases, I've used incus two-stage Darwin reconstruction. Recul means follow-up, so you can see the mean follow-up is 44 months with a maximum of more than 300, and the mean age is 47. The airborne gap closure within 10 dB in my entire series is 93%, which is quite good. And interesting, the most important thing is the complication with the incidence of central hearing loss, which I'm coming to you now, which I think is important. The incidence of central hearing loss, in my experience, was 0.5%. But if we compare the results according to surgical findings, in my entire series, we noticed 93% compared to 89.4% in case of obliterative otosclerosis. But the most important thing is the neck, compared also to 55.6%. But this is the most important thing. 0.5% of central hearing